Chapter 37, Emergencies for Patients with Special Challenges. In this lecture, we're going to cover a variety of topics, including the care and recognition of patients with special challenges, specific diseases and conditions, advanced medical devices, and a refresher on abuse and neglect. This chapter presents many situations that do not fit into the normal expectations of the EMT. Atypical is often typical in these patients. In EMS, we can get called out for a disability in itself as the primary reason for the dispatch, and sometimes we're called out because there's a complication with another illness or injury, and they happen to have a disability as well. Having somebody with cerebral palsy and they're having an asthma issue on top of their cerebral palsy, or we're not getting called for Down syndrome, we're getting called to somebody who happens to have Down syndrome. So it's good to understand that we have to still work around all the basic diseases and ailments and everything that everybody has, any human will have, and then just have different considerations for those that may need more assistance or kind of outside the box. Many patients with disabilities can live independently. Often they'll have some sort of maybe equipment or some accommodations made, but we need to be able to treat them with respect and empathy and autonomy, just like any of our other patients. Think of ways that our ability to treat and assess people with disabilities may be made more difficult, having to go around a wheelchair or to use specific equipment. There's many different types of disabilities. Developmental disability can cover many different aspects. We're going to specifically talk about cerebral palsy and Down syndrome. Other disabilities can be the result of traumatic injury or different medical conditions. You can see the ones listed there, and we're going to cover some of those as well. As stated before, many patients can live independently with some accommodations. In Palmer here in the Valley, we actually have quite a few assisted living facilities where they will live independently, but they are in a facility that has specific accommodations. It could be wheelchair accessible ramps and doorways and lifts. It can have visually impaired accommodations. It can have hearing impaired accommodations. When you have smoke alarms that go off and it actually lights up the entire room, all the lights flash instead for somebody that may be hearing impaired. So it can range what the accommodations can be, and you may walk into a home and not realize that this home has actually been completely modified for the patient that lives there. As talked about before, the visual impairment being a disability, hearing impairment, and then traumatic brain injury. Patients with brain injuries can be very difficult to treat. You need to talk with the patient, you need to talk with the family, get a medical history, and establish what is normal for the patient and what is new. With all of these patients, with all patients in general, you need to explain procedures and reassure that the patient is understanding. With visual impairment, you need to be considerate of the patient ambulation. If any of our patients need a cane or a walker, we need to make sure that we take it with us when we transport them to the hospital. We may need to make arrangements for care, or if they're accompanied by a service dog. Patients should be gently like guided. You never pull them or push them. Nothing like pushing a blind person. Don't want to do that. You want to communicate any obstacles in advance. They may not be blind, but maybe just visually impaired. Being able to tell them that there is a curb in front of them, being able to tell them that something is near them. You never say statements of over there or over here. You want to specify it is in front of you 6 inches, it is just to the right of you, it's straight down in front of your right foot, things like that. Very specific. The problems range from slight hearing loss to total deafness and hearing impairment. It could be caused by nerve damage. It could be hearing loss caused by earwax. So one of the ways that you can communicate if you're unable to do sign language is using a piece of paper and a writing utensil. So being able to offer them that to facilitate communication between yourself and the patient is key. You want to face the patient while you communicate. Many times that they will look at you to read your mouth movements, and it's going to be really difficult with COVID and everybody wearing masks. So if you're able to get a clear shield to cover your face to be able to show the hearing impaired person your mouth movements, it may help, but make sure that your safety is priority. You can see the picture here. Hearing aids do come in many different shapes and sizes, so recognizing the hearing aid will help you determine whether it is just making the sound louder or if they have complete hearing loss. Development with their speech, you can get kind of some cues that they may have some hearing impairment. As you can see here, the patient is having to touch the EMT's face. You may have to allow this to happen. They get a little bit more comfortable with you. It's kind of up to your level of comfort. Explain what you are doing, especially with patients who are blind or have other communication impairments. Different causes of visual impairment could be congenital defect, disease, injury, or degeneration of the optic nerve or pathway. That happens often with aging. They can have different range and degree of blindness. It could be just centralized vision loss or even the periphery, so they don't see around, they can only see in the center. They could have inability to see ranges of darkness or shapes or colors. And some visual impairments may be difficult to recognize. Some people don't realize that they have vision problems because that's what they see. That's what they think everybody sees. So make yourself known when you enter. You're going to introduce yourself and introduce your partners and any rescue that may be there. You can retrieve any visual aids. So if there's something that you can show, that you can get close to them. You want to make them feel as oriented as you can. They may feel very vulnerable. They may feel very disoriented and confused. So explaining to them where things are, especially when you move them into an unfamiliar area, like on top of the gurney, and then moving them into the ambulance. Explaining, we're going to go around this corner. We're going to go over this little bump. You're going to feel this. You're going to feel that. Because sitting on the ambulance with your eyes closed, you don't know where the crew is going to be taking you. Now imagine if you are also having a medical problem and you're already scared that something else is happening, and then you get bumped around and moved around on the back of an ambulance and in a gurney. It's going to be very disorienting and could be very terrifying. Terminally ill patients are actually less about the medical skill, but more about interpersonal relationships, interpersonal communication, and social affective skills to address the death and dying. You can actually make more of a difference in the patient and the patient's family, learning how to communicate and be empathetic with people that are going through a loss. Terminally ill may receive hospice care at a hospice facility or at a home. You may be having to transport somebody from the hospital to this facility or home. They may or may not have a DNR order. They may have specific medical orders for the scope of treatment. You'll see that with our Comfort One. A lot of it is just comfort care. You want to make sure that they're as comfortable as you can get them. We may not be able to provide medication for the patient at the EMT1 level. Asking the nurse or the doctor before you transport them to provide them with pain medication could be something that you ask. Comfort care is also called palliative care. Remember when we go back to our OPQRST, the P stands for provocation and palliation. Provocation is, does anything make it worse? And palliation means, does anything make it better? So comfort care with terminally ill patients is also called palliative care because it makes it better. It doesn't cure it, it doesn't solve all the problems, but it does make it a little more tolerable. It basically improves the quality of life before the patient dies. It makes them as most comfortable as we can get them for the situation that they're in. You want to follow your local protocol, whatever your service requires for DNRs and Comfort Ones and pain management and comfort. You want to also consider the patient's wishes. So if you are allowed to give a pain medication, if the patient doesn't want it, if they are like A&O, they're completely lucid with everything, going with their wishes. If you don't have the ability to provide a medication to provide comfort, many times you can just make them comfortable by keeping them warm, allowing them to sit in whatever is the most comfortable position for them. So if they want to sit up, if they want to lay down, providing them with a pillow, providing them with blankets, just talking to them, communicating with them, finding out about their life. There's a lot more just being there, being a presence, as opposed to doing a medical skill. You want to bring all the documentation to the hospital when you do transport them from home. So if you do have a copy of the DNR, bring it with you. You need to also talk to the family. The family is going through a potential loss as the patient starts to get closer to death. So talking to the family about their wishes, comforting them as best as you can, especially if you are there for end of life. We are a big country, and not like geographically sized, but our population has actually gotten larger in the weight category. Obesity is essentially excessive body fat. Any 20 to 30% over ideal weight. And what causes this obesity or any weight gain is essentially an imbalance between the food that is eaten and the calories that are used. The increase of food, too much food for the calories that are being burned or generated. It could be attributed to low metabolic rate, so they're not burning the calories. You'll see highly active people that are really thin that can eat a ton. You can see not so active people that are underweight and eat a ton. It's just their metabolic rate is much faster. You can have people that are really overweight that eat like a bird, and it's just that their metabolic rate is significantly slower. It also could be a genetic predisposition. It could be in their genes that they're more likely to store more fat. The causes are not completely understood at this point because there's so many different factors. Severe obesity is usually 50 to 100 pounds over the ideal weight. According to some of the CDC standards now, obesity afflicts more than 9 million adult Americans. There's actually a significant number of children in the obesity ranges. There was a lot of memes put on in the last year about people gaining quarantine and COVID weight with the inability to go out and be active. So this country is seeing an increase in obesity. Many times people that are obese are often ridiculed publicly. They may be the victims of discrimination. They may have some fear. They may have embarrassment, and their quality of life may be negatively affected by some of these fears. I have the BMI chart there at the bottom. There is a calculation that you can do, which is the weight in pounds divided by the height in inches squared times 703. I'm not going to do that math when I have a patient. I just basically have an idea-ish of what mine is, and I am on that chart in a not very good color. And I can kind of base that off of other people, what they look like. BMI is not 100% accurate. Nothing in medicine is really 100% accurate when it comes to differentiating different people, because some people have more muscle mass than fat. More people can be, like larger people, what would be considered obese, can be incredibly healthy compared to people that are in that ideal weight range. Mainly because maybe those ideal weight range people are just lazy and sit and they just eat the right amount of food for their metabolic rate, but they have no cardiovascular exercise or anything. So BMI is kind of subjective because it does change with different people. It's not a perfect system. People that are obese can have some associated health problems. They're more likely to have diabetes, especially type 2 diabetes. They're more likely to have high blood pressure. They're more likely to develop heart disease, because what I was saying before is it's an imbalance between food intake and calories burned. When you're eating like veggies and stuff, it's hard to get those really high calories in the veggies. What's really going to cause those high calories is going to be high fat and unhealthy foods. Those high fat and high salt and unhealthy foods are going to cause more plaque buildup. They're going to cause a breakdown of blood vessels. So those things in turn are going to create high blood pressure issues. Usually people that have a high intake of calories, maybe it's high in sugar. Too much sugar, the body's going to start having more and more issues creating that insulin, so they're going to start developing more of a diabetic problem. And all of these factors kind of feed into each other. You get hypertension, you start having heart problems, you're less likely to be active because you're out of breath or your chest hurts, so then you gain more weight, which causes more issues. So it's this never-ending cycle that's really hard to get out of. People struggle with losing weight. Chronic pain when you go walking, pain on the joints, pains on the knees, and osteoarthritis from all the weight. It's going to make it harder to do any aerobic exercises to be able to increase that caloric burning. So try to get a very extensive medical history, asking about diabetes, heart problems, heart conditions, any medications, last oral intakes, their activity. Try to get an idea of if you're dealing with different comorbidities along with this. Plan early for any extra help. If you do see a patient that you're going to need additional lifting, make sure you call it early. And try not to embarrass. They may fear embarrassment or ridicule, so they may not have wanted to call EMS until it's pretty much too late. I don't know if you guys have ever seen What's Eating Gilbert Grape, but the emergency responders there were just cruel, talking about like how large his mom was and having to cut hole in the side of the building. It was just better to just burn the place down. When you walk into the home, If there's an area where you don't have to take stairs, and lifting the patient up the stairs would be more preferred. So try to find the easiest and safest route, even if you have to move the ambulance to a different area of the yard. Try to find out what is the most safest for yourself as well as the patient. You don't want to risk dropping the patient. You could injure a team member that way and injure the patient. And you want to make sure you treat them with dignity and respect. Try to maintain their modesty, covering any body parts or anything that may be outside of like the blanket and the straps. Talk to your patient. Ask them how it is best to move them. Like, don't just assume that you're going to pull here or pull there to be able to lift them up. Ask them what the best way is. Avoid lifting a patient by one limb. Remember that our joints, when you go into your trauma sections, we learn about traction splinting and joints. If you lift a patient by one limb, you're putting a lot of strain on one joint. Joints are not meant to be pulled in extremes. So you don't want to overtax the joints. Try to lift by multiple limbs. You need to communicate and coordinate all your moves to all the team members as well as the patient. Cerebral palsy is a group of disorders characterized by poorly controlled body movement. Symptoms can include poor posture, uncontrolled spastic movements of a limb or more, visual and hearing impairments. They can have difficulty communicating. They can have epilepsy. They can have developmental delay. 75% of patients with cerebral palsy have some sort of developmental delay. They can have unsteady gait. They may need a wheelchair or a walker. If they do have a wheelchair or a walker, make sure you transport them with the patient. You need to pad the patient to ensure comfort. Never force an extremity into a position. The previous picture showed his arm kind of facing a different direction. That is his normal. So never force it into what we consider normal or average. That is his normal. Whenever possible, you're going to take the walker or the wheelchair along with the transport. Be prepared for a seizure. So that also means keeping suction available. Patients that are homeless or impoverished can be very difficult. Try to think of how homelessness can affect the physical well-being of somebody. Are they going to be warm enough? Are they going to be cooled down in like extreme heat? Are they going to be surrounded by bugs, mosquitoes, snakes, rats, spiders, who knows what, being outside of a shelter? Are they able to provide themselves with basic needs? They may not be able to afford housing, but are they able to eat? What are they eating? How often are they eating? Many times, homelessness is actually a symptom and an issue with mental health. It could be a mental health issues that has caused them to become homeless. Maybe they have been kicked out of a home. Maybe they're a youth or a teenager that has been abused, and it's better to be homeless than to be in the environment that they were in because it was no longer safe. We need to be an advocate for all of the patients, regardless of what their cause is. We need to care for them like with any of our patients. Become familiar with any social services in the community. Here in the Valley, we have My House, not Brianna's house, but a facility called My House, where youth that have been displaced or homeless can go. We've got the women's shelter in Palmer. There's the homeless shelters in Anchorage. There's different facilities that they can go to. There may be some social services that can provide some sort of assistance. Just communicating your empathy and your care for them can help alleviate some of the embarrassment or ridicule and fear that they have been feeling. Many times people that are homeless are addicted to substances, whether it's alcohol or other drugs. So you do have to be aware that there could be some behavioral issues, there could be some violent issues. You have to be looking for those things all the time. Just like anybody can be addicted to drugs and alcohol. It's just a lot more common in areas where there is poverty and homelessness. Spina bifida is an incomplete closure of the spinal column. Basically, while we're developing in the womb, the spinal column, where all of our body starts, and then it gets wrapped with different tissues and muscle on our body structure and bone, and then the outside would be the skin. It actually is an incomplete closure of the spinal column with some undeveloped vertebrae. So it is damaged basically from that point and lower. They may have partial or full paralysis of their lower extremities. They may have loss of bowel or bladder control. And interesting enough, they could have an extreme latex allergy. Other causes of paralysis could be stroke, trauma, and again, the birth defects, including spina bifida. It may require its own equipment, and it has its own complications. So if it's just one side of the body that is paralyzed, let's say we have a stroke and the left side of their body is paralyzed. When you do a log roll or you want to roll them over, you want to roll them onto the paralyzed side. Why is that, you think? So if I am unable to use the muscles on my left side, and then you put my full body weight on the right side, my right side is having to do all of the work. So put me on the left, put me on the paralyzed side, because at least then the part of my body that is working is able to function without having my entire body weight on it. So think differently than a trauma. In trauma, you don't want to put pressure on the broken part, so you want that up. But this, you don't want to put pressure on the only thing that's actually working. Ask the patient how it is to best move them. If they are able to do some movements on their own and they have the mentation to do so, allow them. Give them that ability to provide their own care, to be able to have some like they feel like they are able to provide their own care, or I'm trying to think of the word, autonomy. They are part of the decision-making process. They still have the ability to care for themselves and make those decisions, so they're not just being completely taken care of. Sometimes people have that specialized equipment like I was talking about. We're going to cover these later in the chapter, the urinary catheters and trachs and colostomies, feeding tubes. Many times with paralysis, they're going to have difficulty swallowing, so always having suction ready. This next section, we're going to talk about different approaches to care of patients with special needs. It is normal to feel uncomfortable. You need to treat the patient as you would with any other patient. You're going to approach in a calm and friendly manner, and you're going to establish rapport. You need to introduce yourself as well as all of your team members. I was saying earlier that patients with brain injuries may be difficult to treat. You need to get a full medical history. You need to, with all patients, you need to consider what is normal for them and what may be abnormal. Patients with an autism spectrum disorder will not behave or react in the same manner as most patients do. They are best cared for by avoiding sensory, emotional, or cognitive overstimulation. We're going to cover the mnemonics ABCS in the next few slides: awareness, basic, calm, and safety. Be aware of some of the differences in people that are on the autism spectrum. Some people with autism do not have a normal range of sensations and may not feel the cold, heat, or pain in a typical manner. Many fail to acknowledge pain in spite of a significant pathology being present. They may not be able to express that. They may show an unusual pain response that could include laughter, humming, singing, removing clothing. People with autism often have tactile sensory issues, so consideration of Band-Aids and other adhesives could increase their anxiety and aggression. Keep your instructions basic and use clear and simple instructions. The patient with autism may not offer typical complaints. They may have very high pain thresholds. They may choose to engage in a pleasurable activity rather than deal with an obvious injury or medical condition, despite their level of discomfort. You want to move slowly, performing exams distal to proximal. Start further away and then work in. Explain what you plan to do in advance and as you are doing it. Explain where you're going and what they may see, who might be there. This may avert some of the unnecessary anxiety or outbursts or aggressions from the patient. People who appear not to understand may have better receptive language, which is not entirely evident. If it is possible, ask a caregiver what level of support the person with autism needs. Then treat accordingly. Maybe it's stickers or stuffed animals. You can use that to calm a young child down. It may even be helpful with some of our older patients. Attempt to perform exams in like a quiet spot, if at all possible, depending on the severity of the injury and, of course, the safety of the scene. Demonstrate what the exam will consist of on another person before you do it with the person with autism. Sometimes that will help, having that visual aid, so they know what your intentions are. Expect the unexpected. Children with autism may ingest something or get into something without their parents realizing it. Look for less obvious causality. Inspect carefully for other injuries. Dealing with children with special needs, there may be different medical challenges. Sometimes they can come with specific equipment. It's important to get a copy of any information that you have from the parents or caregivers to be able to transport with the child. General considerations in responding to patients with special challenges. Many times when you are responding to a patient with special needs, they may have specialized home medical equipment. Many times this can cause a problem for the EMTs. They may not know how to use the equipment. They may be very unfamiliar with the equipment. We're not going to cover all equipment, and equipment's being developed all the time, new devices, new techniques. But being able to understand the basics of what these devices are for can help you recognize whether it's a problem with the device or if there's a different medical or traumatic problem unrelated to the device. As our population of geriatrics is increasing and our medical knowledge and skills is improving, we're actually seeing more people on advanced medical devices at home. People that would have died generations ago are actually being kept alive and are actually participating in activities and being functional. But they have to have equipment and medical devices to help them, to assist them in their daily activities. So we're actually seeing an increase in this. Become familiar with different facilities in your community, in your area. You may have to respond to private residences, nursing homes, specialized care, or even rehab facilities in your area. So recognizing different entrances, using a sally port at a facility as opposed to a driveway, or parking there. If you know that the assisted living facility has stairs in the front, but they have a ramp on the side, being prudent to park the ambulance at the side entrance instead. The caregivers of the patients with special challenges often are the most valuable resource for their assessment and treatment. You're going to get more information from them than many times you can get from documentation, paperwork, or the patient themselves. Be aware that sometimes family members, if they are placed in the role of caregiver, may have difficulty using the skills that they have been trained in the case of an emergency. Yes, they've been trained to deal with the equipment, they've been trained to manage different situations, but when there's an actual emergency involving their loved one, they may not comprehend their training. They may not be able to do the skills that they were trained to do. So having a little bit of coaching may help them overcome that stress, that inability to go back to their training, remain calm and stable, and give them that encouragement that they did their job. They felt overwhelmed and they did the appropriate thing by calling EMS. Although EMTs, paramedics, nurses, regardless our level of training, we may not know the most information, the best information. We might be the least informed person in the room. Talk to the caregivers and talk to the patient. The patient's going to have a lot of information. Sometimes we'll have a lot of information regarding their condition, their need for a device, the operation of the device, how to use it, how it charges, how to carry it, all of those things. So be humble in the fact that we are not going in there as subject matter experts. We do have to rely on the people that are in the room to help guide us. So different ways that you can get information on the healthcare setting could be from the patient, it could be from manuals, it could be from the nurses, the PCAs, or anybody that may be in the room, or caregivers. There's other resources. You may be able to watch a video on how to do it, have your partner look different things up. There may be different ways to get information on how to use the equipment. Maybe your partner, although you may be in charge or lead on this, maybe they have some experience with it. Maybe they have a family member that has used this equipment before. So talk to each other, find out what is the best means of ratifying this issue or working with this device. Find out where you can get this information in the room and outside the room. Regardless of the training you receive here, you have to follow your protocols for your state and your service. There's so many different healthcare challenges and so many different devices and equipment that there is no generalized rule on how to work on that equipment, move that device, alter that device, take over that device. So really you have to fall under what you're allowed to do per your state, your region, and your service. It can be common to encounter a problem or situation or condition that you may be unfamiliar with when you're working with patients who have special challenges. It is okay. You recognize when something is wrong, strive to provide the best care possible under the circumstances. And the only way you're going to know if something is wrong is to find out from them if this is normal, if this is their baseline, what's different. So ask them, what is different about today? Why did they feel that an ambulance was necessary? Be aware that family and caregivers may be doing something that is outside your scope of practice. So educate them on what you're allowed to do and be considerate of what they're going to be doing. They're often very well versed in procedures that they're supposed to do for their equipment and for the patient. Sometimes patients with special care needs have routine medical problems. It can be easy to lose sight of these basic problems during the call. So routine problems may exacerbate chronic conditions. Don't focus so much on the chronic problem. You may miss that routine problem. You may miss the asthma problem. You may miss the diabetic problem if you're too focused on the equipment. You're too focused on, maybe it's a problem with their ventilator and they have a trach. So you're too concerned with that when really you should be getting a blood sugar. Maybe that's the problem. They're usually more awake and alert, and today they're kind of obtunded. So don't assume that it's the chronic problem, that it's actually something a little bit more routine, what we see in medicine every day. It could be something that you have been trained to deal with on a daily routine call. Now we're going to cover some specific diseases and conditions and how it could be a primary problem or a secondary problem. A congenital disease or condition is one that is present at birth. It could be something that they got through their genetics, or it could be something that it was not genetically caused, but it was still presented at birth. An acquired disease is a condition that occurs after birth. It may be the result of exposure to a certain virus or a bacteria. It may be the result of other medical conditions or trauma. An underlying disease may complicate another illness or injury. You can have an exacerbation of a disease. Acute illnesses may be more devastating because of a coexisting chronic disease. Consider a patient with a chronic disease. What challenge might the treatments of the disease pose to the patient? We have somebody with COPD. They have the increased carbon dioxide. It is triggering them to breathe. So giving them oxygen when they're having an exacerbation of their COPD is preferred, but too long exposure to this increased oxygen is actually going to make their drive to want to breathe more difficult. Specific diseases and conditions include developmental disorders, which can include mental retardation, insufficient cognitive development of the brain, the inability to learn or socially adapt at a normal developmental rate. These can be caused by the genetic or congenital causes. It could be complications at birth. Maybe they got stuck in the birth canal. It could be malnutrition. They're not getting enough minerals. It could be different environmental factors, too hot, too cold, caused some of the damages. It could be trauma, fetal alcohol syndrome, and it could be from different poisoning, like lead or other toxins. Patients with developmental disabilities are susceptible to the same diseases as other patients. They may be slow to understand or have limited vocabulary. They may behave immaturely compared to their peers. If their developmental disorder is severe, they may have inability to care for themselves, the inability to even communicate or understand or even respond. Advanced medical devices. Biggest thing with advanced medical devices is asking what is different today. Interact with the caregiver, interact with the patient, find out more about the device itself, to determine what is normal and what is abnormal. When encountering an advanced medical device, you must take into consideration what the device is doing for the patient and how important the device is to the patient's survival. These are some of the different medical devices we're going to cover. You can see pictures here of the LVAD. You can see a picture here of the vagus nerve stimulator, and there is a tracheostomy tube there on the left. The LVAD in the middle, and the vagal nerve stimulator there on the right of the screen. We're going to cover some of the other ones as well. Some of the respiratory devices include Cpap, which you guys learned a little bit about that in more of the respiratory section. When encountering this medical device, you need to determine whether this is important for the patient's survival at this time. Maybe they use the Cpap only when they sleep. You have to understand how the Cpap is working. It is going to be a little bit different than the BiPAP, which actually helps with inhalation and exhalation assistance. Many times people can go without their Cpap. If they use it at night, there's less likely to have an emergency related to this machine. You can have the patient bring the machine to the hospital if they're going to be staying. You need to alert hospital personnel the use of a Cpap device, whether you're using it on the patient or if they're using the device at night to help them sleep, whether they have sleep apnea or other reasons to be using the device. This here is just one example of Cpap. Again, it's a non-invasive positive pressure ventilation. We're not actually going into the body. They're just using an outside source to be able to provide that continuous pressure. It is often prescribed to people that just have sleep apnea. Anytime you hear stoma, it basically means a surgical opening. So if you look at the tracheo, meaning the trach, and ostomy, meaning the hole, it is a hole in the trach, a surgical opening that they're actually taking over that airway. They're putting a tracheostomy tube or the trach inserted into that opening, and it allows the patient to breathe. You can actually attach a BVM or a bag valve mask onto the end of the trach. You aren't going to be putting it on their mouth. You're not having to put an OPA or MPA in. You're actually going to be able to put that directly onto the tube. And an obturator is like it's like a device that goes into the hole, and then you put the tracheotomy tube over it to help insert the tube into the ostomy. Some patients that are on long-term breathing assistant may have long-term tracheotomy for those conditions. The trach tube is inserted in the opening. It will allow the patient to breathe. They may or may not have to have a ventilator, and they may or not have the ability to speak. So they may have to write things down. They may have to use sign language. They may have to have somebody interpret for them. Mucus buildup is the most common problem. They're not able to spit like we do. We're not able to get a lot of that mucus out. So they may need some additional suctioning. It could be dislodged because they cough when they have a lot of that mucus, and then there could be some infection because they're not able to get that mucus and that bacteria out. You're going to assess the tube to see if there's a problem with it. It could just be that they have a tube to help them breathe. Always goes airway, breathing, circulation. So checking that airway. Yes, their mouth is no longer their airway. You have to assess this new airway. You're going to check for a blockage. Is air moving in and out? Is the ventilator working? If it is blocked, see what's blocking it. See if it's an obstruction of the tubing itself. Determine the depth. You're able to see if there's anything in there using the obturator. You're going to provide suction. Always use suction on the way out. We never suction on the way in. You want to use the BVM to be able to ventilate for them if the ventilator's not working. And transport with the head slightly elevated will help so fluid doesn't come back down to it. There could be bleeding or air leaking around the tube. The tube can be loose or dislodged, and the opening around the tube may be infected. So observation around the tube is important, and you need to document all of this onto your PCR. A ventilator is not the same thing as a Cpap or BiPAP. A ventilator is a device that artificially breathes for a patient. So we're checking airway, and now we're checking breathing. Common problems include a mucus plug or mechanical failures. So the mucus plug actually affecting the airway as opposed to the breathing part, as opposed to like the ventilation. Now mechanical failures could be a problem with the ventilator itself. If the ventilator is unable to be fixed, we're going to have to go with our own mechanical ventilation, which is going to be our BVM mask. So taking the mask off, attaching it straight to the trach is going to be one way that you can do it. Sometimes people are intubated when they're on a ventilator, and then you can hook the BVM directly to that. Pay attention to your rate, pay attention to your end tidal and your SpO2. Another assessment tool that we use is the DOPE mnemonic, which is displacement of the tube. Maybe it has been moved or dislodged. You're going to use this for ET tubes as well, or any airway device. It could be an obstruction or a mucus plug. Maybe there's a big spit glob, a phlegm glob that's plugging it. It could be a pneumothorax or pneumonia, so there's actually a problem in the chest lung cavity. And then it could be the equipment failure itself. So the first thing that we look at is airway. We're looking to see if it's plugged, if it's clogged, if there's something going on at the other end of it with the lungs. And then we're going to address the issue of the equipment itself. Maybe the equipment that's providing the breathing is actually the issue. Use a BVM while moving them into the ambulance. You're not having to lug around the ventilator equipment or the large apparatus. The BVM is going to be much more portable, and then you can secure the ventilator to the patient afterwards. Make sure that your protocols allow you to use the ventilator. Some protocols do not allow that, and anytime the person is being ventilated, and honestly, anytime you have a patient, you should be doing end tidal CO2 if that's part of your protocols. But anytime they're on a ventilator, that is going to be a definite must. Modern pacemakers are more rate responsive. That means that they detect what the patient is doing and then modify the heart rate accordingly. That's usually a very low energy pulse that's typically not felt by the patient, and it's not detectable in the skin or felt by the provider. If you're like touching the patient, you're not going to feel a small electrical impulse. But many times they do detect whether the patient is going to be more active, and then they'll modify that heart rate to increase that cardiac output as needed. With pacemakers that are also cardiac defibrillators, they're going to help increase that rate, but then they can also detect VFib arrest and like shockable rhythms. A single shock is delivered when a life-threatening rhythm is detected. It may offer other shocks. The patient will feel these shocks. Typically, the implant is in the upper left chest. So when you have to put pads on the patient, if you're going to attach an AED or cardiac monitor, you can still put the AED or monitor on using the right chest, right pec, and then the left side, left lateral, because typically these pacemaker defibrillators are again on the upper left chest. Sometimes they kind of look like a small Altoids can just underneath the skin's surface, or like a small carton or a small deck of cards, or like carton of cigarettes or something just underneath the skin of the chest. If you're dealing with a patient that is called regarding their pacemaker or defibrillator, you need to consider advanced life support to be en route. This is something that is beyond an EMT basic, EMT 1. If the patient goes into cardiac arrest, you're going to follow CPR and AED guidelines, whatever your service provides you with for CPR and AED guidelines, doing compressions and shocking as the machine or as your service requires you. Be aware that many people that have pacemakers and defibrillators may have a DNR, so get this information prior to transport. Provide high level of oxygenation and frequently reassess this patient. The defibrillation works with the life-threatening like VFib, VTAC, those type of life-threatening dysrhythmias. Some people can actually wear a cardioverter defibrillator where they have a dysrhythmia, but it's not necessarily VTAC or VFib. And so they're going to have a different type of shock. It's going to cardiovert, which is a little bit different than just a standard defibrillation. It may have different voice commands to the person that's wearing the cardioverter defibrillator. You should provide CPR unless the device has a voice command saying do not provide CPR, or if they have a DNR or Comfort 1. Go with your service protocols, and when in doubt, call for medical advice. Ventricular assisted devices, especially the LVAD, which is your left ventricular assistant device, is basically a mechanical pump that takes over the pumping action of the heart. The heart no longer needs to pump. If you go back several slides, you see that picture of like a device attached to the heart, and it's got like tubes and stuff. If you want to go back there, totally rewind this video. It's neat because it takes over. It's almost like having a robotic or mechanical heart. It mechanically pumps the blood throughout the body. These people will not have a pulse. They actually will have a pump whirring type fan sound. Take your stethoscope anytime you have a person that has an LVAD, because they can be calling for other things. They're on all sorts of different medications to prevent clots. So if I had a patient that had a nosebleed and his nose would just not stop bleeding. And on my PCR, I wrote that I had an LVAD patient, and my chief at the time was like, whoa, you didn't transport him? He was a refusal? I said, yeah, he didn't have an issue with his LVAD. His LVAD was fine. He just had a bloody nose, and we fixed that. And he didn't want to go to the hospital. So I documented everything I could. The set of vitals that I got from him, you're not going to get a pulse. You can use a Doppler and essentially get a blood pressure-ish there, but you're not going to be able to determine what we classify as the typical systolic and diastolic. They will have a port where they plug in. They do have batteries. So this has actually caused people that have had really, really bad heart failure. They get up and they're out of breath. They can't walk to the kitchen from their bedroom without being out of breath. And then they get one of these LVADs placed in, and they're able to go on walks and hang out with the grandkids, and they actually have very like fruitful last years of their life. Typically, the batteries die out after about 6 or 7 years, and so these people more often than not will have a DNR or a Comfort 1. There are some there's a lot of research being done on whether CPR is going to be really indicated, because remember, it's taken over the pumping of the heart. The heart is no longer pumping. So if the battery stops, you doing compressions, is that going to dislodge this equipment and cause significant bleeding? Is this going to be even effective if you're just squishing it? If the battery's dead, using a defibrillator, using an AED, is that going to have any effect on it? Because the heart wasn't doing the pumping, it was the machine, and the machine's battery is dead. And I'm not meaning like the battery died as in they forgot to charge it. I'm meaning the battery can only charge so many times before it has to be replaced. So they're looking at this equipment, doing a lot more studies, and it is actually getting longer and longer battery life. When you do get a patient that has an LVAD, you need to take your stethoscope and go over, like, listen to the heart and listen to the beeps. If it has an error, it will beep so many times. It may just be like a Morse code. So determine what the beeps are doing, and you're going to communicate that to the hospital when you do your report, because they need to get a hold of a cardiologist that is familiar with this device, familiar with this patient, and determine 3 long beeps means there's a low battery alarm and the patient hasn't been charging himself in, plugging himself in at night. Or maybe the 3 beeps means that there is some sort of other mechanical issue. It could be that it has experienced some sort of leak, that there may be some air leaking, or that there may be some blood leaking. And it has those little error notifications. So listen to the pump. It should have like this beautiful little purr sound as it pushes the blood around. So this here is just a little bit more information. Assess the patient. Look at the patient and not necessarily all the gadgets and gizmos that we have. Talk to them. They know a lot about this device. So this patient here is, the book states that he's looking for a suitable donor. He's waiting for a heart transplant. So he's wearing this LVAD as kind of a bridge to a transplant. Moves blood from the left ventricle and pumps it through the rest of the body. It sends the blood into the aorta that gets transported everywhere else. He wears essentially a belt, which is the battery, and the device plugs in. He's wearing all these, like this harness and everything, to carry the weight of the battery and the devices. The device itself is in him, and then he's got a port that sticks out of the skin that he can plug these devices into. Feeding tubes are used in patients that cannot feed themselves or cannot swallow. This can be short-term from like a recovery from like surgery, or it could be from chronic conditions. It could be from stroke. It could be from different mouth cancers or throat cancers. It could be an NG tube that goes in the N or the nose into the G, which is the gastric or stomach. So nasogastric NG tube goes from the nose into the stomach. It can be used to deliver nutrients there. Gastronomy tube, or G tube, is a feeding tube that goes directly into the abdominal wall and into the stomach. So this is a surgical one, the G tube is. Common problems are very similar to the airway tubes, the airway device. So dislodgement, and it could have an infection. It could be clogged. It could be bent. It could be displaced. So there's different issues that they may have. Now, considering this differently than our airway. Our airway one, you die airway, breathing, circulation. You will eventually die from starvation with not getting any food, but it's not an immediate thing. Infection usually takes a little bit of time as well. But if there is other damage that maybe they have a bleed, they could end up bleeding to death if something has been dislodged or ripped. You need to assess and transport the patient with the feeding tube attached to their body, so you can use tape. We discussed earlier about some developmental delayed patients or those with autism may have more sensory overload with some certain tapes. So again, talk to the caregiver, talk to the patient, try to find out what's the best way to transport patients. Try to keep the nutrient above the patient in the tube, because you don't want the stomach contents to flow back out into the source of the food. You want it to flow the right direction, which is going to be into the stomach. You can, when they're done feeding or when they're done their source of nutrients, there is a cap that you can place over it so stuff doesn't come out and air doesn't go in and kind of fill them up with different air movements. Well, we do not place any dislodged tubes. There's probably a reason that it was dislodged. So if it does come out, you're going to transport it with them. Try to put them in the most comfortable seated position if possible. We definitely want to be very aware of things that kill people more quickly. So again, airway, breathing, circulation. When it comes to feeding tubes, the biggest thing is going to be the circulation. You need to assess for any signs and symptoms of bleeding into the stomach. Do they have different abdominal discomfort than they've usually have? Is there nausea? Is there vomiting, especially that coffee ground emesis? Is there any blood when they do vomit? They do have an increased risk for aspiration if there is an overload of food, or there's an overload of oxygen being able to push that food out. So you need to make sure that you have suction ready. They may have difficulty breathing if you lay them down. So make sure that they are sitting up a little bit. Urinary catheters are used for patients who have lost the ability to urinate or control their bladder. Most commonly is the indwelling or Foley catheters. There's also condom type catheters, which are essentially what they sound like. It looks like a condom and it has a tube at the end, and you will have the gentleman, he'll place it on himself or have somebody else place it on him for him, and the tube then flows to a collection bag. Maybe sometimes these bags are strapped to the patient's leg. They could have an intermittent catheter where as their bladder gets full, a nurse or caregiver comes in, places an indwelling catheter, the urine is expelled, they put it into a container, and then the catheter is removed. So it's not a more permanent. The Foley catheters actually have a balloon, so when the tubing is inserted, the balloon is inflated so it stays in the bladder. What's really common with traumatic brain injury patients is they will yank this tubing out. The balloon is quite large. Think of the size of a nickel or even up to a quarter, and that is now being ripped through their urethra, and there could be some significant tearing and damage done. So pay attention to the patient and what they're grabbing, and don't allow them to rip that tube out. You want to try to keep the urinary bag or whatever the catch bag is below the patient, because you don't want it flowing back into the bladder. You want to make sure that it's secured so it doesn't spill anywhere. You want to document the amount, any discoloration or odor. You want to document that it was transported with the patient. You don't want it squished between the stretcher and like the wheels, so paying attention when the stretcher gets moved up and down so it doesn't get accidentally sucked into any of the brackets, braces, or like movable parts of the stretcher. This here we see the gentleman, he has a Foley in, and you can see the bag. Well, he possibly could have a condom cath that he left on, and it's attached to the catheter collection bag, so he's able to walk around and go about his day and keep his urine with him. Ostomy bag, again, stoma being a surgical hole. Ostomy bag is basically collection from the colon, or colostomy or ileostomy, so the ileum. It's usually not visible through clothing because they do want to cover that up. We need to assess that, make sure that it's not full and like getting ready to burst the pouch. You do not want that. Definitely do not want that. Transport the patient. Try not to allow it to get broken or dislodged. Don't want to lose that bag. Dialysis is patients that may have some sort of renal failure. Basically replaces the functions that the kidneys have lost. It removes toxins, it filters the blood, and it regulates their fluid levels. Now there's a couple different ways that somebody can go through dialysis. Hemodialysis, hemo meaning blood, is performed with a dialyzer or a machine. Most of the time they do have to go to a dialysis center. They will have a surgical AV fistula in their arm, and it's going to look like some wicked veins. And what it is they've taken an artery, the A, and a vein, V, AV fistula, and they've fused them together. So it only takes one needle to go in, and they're able to grab blood, filter it through the dialyzer, and then put it into the body again to be able to cycle through blood rather quickly. Other complications from it, since they are on, they do have this this connection of the AV, you could have a venous bleed, so it could, or an arterial bleed from the AV fistula, so they could bleed rather quickly. Since they are being stabbed with a needle over and over and over, they could develop an infection. People that are on dialysis are more likely to have fluid overload if they miss a session, and they can get rather sick very quickly. Besides hemodialysis, which we talked about was the machine and blood, there's also peritoneal dialysis, which people can do this at home. Essentially, their kidneys still work a little bit, and what they're going to do is they're going to put fluid into the abdominal cavity, and then it goes into the abdominal cavity. The solution is absorbed. The solution absorbs any wastes from the body. So a lot of the stuff, our body starts to put a bunch of stuff in there because it wants to kind of even out the fluid in the body and the fluid outside. So all of the extra nutrients, the salts, the waste gets into this nice clear, nothing in it fluid to kind of even it out. And then we're able to take that fluid out of the body and put it into the outflow container. So you can see on the picture there, the dialysis solution goes in. The body goes, oh, there's a bunch of clean fluid. We need to even out. So it starts putting all this other like nutrient stuff into that solution. And then that solution then follows gravity again and goes down. So there are some complications that can happen from this. It could be dislodging the catheter, there could be infection, and so the peritonitis there is infection of the peritoneal cavity. The biggest difference from hemodialysis versus the peritoneal dialysis is hemodialysis requires an artificial kidney machine that filters the blood, while the peritoneal dialysis works with a lower functioning kidney that's able to still work. So we need to assess our patient. You're going to assess them head to toe, just like anybody else. Do not mess with the arm with the AV shunt. Don't poke it, don't prod it, don't take a blood pressure on it. You're going to observe it, and then you're going to go to the other arm. A rupture of this fistula can cause significant blood loss. If you use, if there is a puncture to it, you need to use direct pressure. Treat it like an arterial bleed, and you're going to treat for shock. People may have more permanent IV catheters placed into their body. Central IV catheters, they are surgically inserted. They can go there at like the collarbone and go directly into the central circulation by the heart. PICC lines, so the peripheral inserted central catheter is another surgical one, but it is further away from the chest. Usually it's found on the arm, but it's still going to be threaded into the central circulation. More common here is going to be issues of infections over time and degradation of the skin around it. It does take a sterile environment to manage central IV catheters because they're high risk for infection. It goes directly into the central circulation, directly into the heart. So if an infection is found, it's going to go right into the heart. Other problems could be broken lines, it could be clotted lines, it could be bleeding around the line or from the tubing attached to it. The needle that you see there is specifically designed for an implanted port. The implanted port has no external tubing. So you have this needle that actually pushes into the port underneath the skin. Since there is such a high risk for infection with your PICC lines and central lines, we need to restrict any use of it to hospital personnel only. We don't want to be flushing any fluids through it. We don't want to be tugging it or contaminating it at all. Try not to place an AED pad over it. We can go front to back instead, or maneuver it just a little bit to the side. Have a high index of suspicion for sepsis. Remember, this infection will go right to the heart. So if they're having any sort of altered level of consciousness, definitely suspect sepsis. So VP shunts, peritoneal. So it's the ventricle of the brain to the peritoneal, which is going to be the stomach. It is a drainage device. So children, many times it's in children with special needs. It takes the pressure off of the brain. So if they have some sort of, they've lost the ability to shunt on their own, and there is some sort of fluid overload, so extra cerebral spinal fluid in the ventricles, it's going to cause more pressure in the brain, and so they have an artificial shunt that will take that fluid, and we kind of get rid of it into the abdomen where it can be reabsorbed into the tissue. There could be a high level of risk for infection. So be aware that there could be an issue because it is going into fluid, it is going from an outside source into the body, so there is potential for some sort of infection there. When you're transporting a patient with a VP shunt, be very aware that they can develop seizures and they can develop respiratory problems. There's more concern with pressure on the brain, and this pressure could develop into a seizure, or it could slow down their breathing. So you want to manage their airways and prevent any hypoxia, and you want to transport with any of the devices that they may have. They may have other machines. You need to call medical control for any specific instructions regarding these that may not be covered in your protocols. When managing patients with any physical impairments, you need to take extra time and care to help these patients. We talked a little bit about this with hearing, sight, speech impairments, physical impairments with gait. Just because that they have a physical impairment does not mean they have a mental impairment. People with cerebral palsy may not be able to use their limbs like they would like to. They may not be able to walk or talk without difficulty, but that does not mean that they have a mental impairment. They are fully aware of what's going on. Impairments to sight, you need to determine whether vision is poor or if there is no vision. Same thing with hearing, determine whether it's loss of hearing or hearing impaired. It's nice to have a small flashlight with you. You should have one in your kits in case the lights do go out. They might not be able to see that the lights went out because they are blind. If they do have a guide dog, you need to transport the guide dog unless it is like a life threat, or if you don't have the time or space, or it's a hazard to transport the guide dog. But you really do need to consider that that dog is now part of that patient. More physical impairments. A wheelchair may make it very difficult to assess the patient. They may not have sensation below the waist, so we do need to assess them at the chair level. We are looking for bed sores, especially if you're going to move the patient to a stretcher. You need to do a thorough exam and see if there is any damage to their skin from sitting on a wheelchair, and then bring the wheelchair with you. It's kind of tight to find it to place it in the ambulance, but do what you can to bring it with you, because when they do get released from the hospital, they need to have the ability to get home. So their wheelchair or their cane or whatever they use. I want you guys to think about how you would navigate through your house if you had blackout sunglasses on, or if you had like dual hearing protection on. So you had earplugs in, and then you also wore earmuffs to make it so you really couldn't hear that well. And then try to navigate through your home. Or have a conversation with somebody wearing either one of these. What's your comfort level with that? Are you feeling stressed? Because that's what your patient may be going through. And you're not hurt, you're not feeling sick, and you're having to do this. So try to be considerate of their comfort level and try to figure out what tools would be needed to help compensate for this, this impairment. I'm only going to quickly go over the abuse and neglect. You had a large section, I believe it was chapter 4, that covered a lot of abuse and neglect. So this will be a lot more of just a review. The reason that this is in the special needs section is that patients with special needs, special challenges are more vulnerable. They put a lot of strain on the caregiver. They put a lot of strain on the staff around them or people around them, landlords, because they're frustrated that the patient has all these extra needs. They may have more fears and embarrassment issues. There's a lot more potential for abuse and neglect due to their dependence on others. You need to be able to assess for some of these signs of abuse and neglect. Some of them could be from physical abuse. It could be from mental or emotional abuse. So being aware and looking for these, have a high index of suspicion when it comes to people with special needs. So just like the other section, do not make accusations. Do your best to get the patient out of the environment and report it as required. So child abuse, elderly abuse, and special needs to be reported. Now those that are homeless, that's not a reportable thing for necessarily to report any abuse or neglect, but it really depends on the situation or those that are obese. Again, there's no regulation on reporting suspicions of abuse or neglect, but be aware that there may be some abuse, neglect, or like violence surrounding any of those people. So you start to see that there's different stories from a parent with a child. Maybe they are inconsistent with their story, and you are more suspicious of your findings. Don't go with like, what if you're wrong? Try to think about what if you're right about your suspicions and how you could actually make a huge difference in this child's life by making the report. Here is a couple examples of some neglect. Some more examples of some abuse and neglect that we had talked about earlier in Chapter 4. Some common findings for some physical abuse. Not all broken bones in little kids are from abuse. Kids are accident prone, so the story and the age is appropriate for certain bruises or bone breaks. A toddler that's not able to walk shouldn't have like specific kind of injuries. If that's all they can do is crawl, then how did they get up on certain counters or off certain things? So really just pay attention to the story, and if things don't start to add up, have a higher index of suspicion. Some more indications of abuse. There could be, it's a little different than helicopter parenting, where the parent is like all up in arms, not up in arms, but all over you, like following you like a shadow. They could actually be concerned, or they could be concerned that you are going to find something that they don't want you to find. While you're treating the child, you should keep an eye on the parent and see how, or the caregiver, and see how they're reacting or acting. Look around the room, see if there's any signs of drug or alcohol. Get a kind of a feel for how they're reacting to the situation. It's sad, but it happens. There are times you may have to assess for sexual abuse of a child. With any of our patients, we really only examine the genitals if there is a need for it, or if there is suspicion of some sort of injury there. You need to be calm and reassuring. This could be very intimidating and scary for them. They may feel like it is their fault. So we need to make sure that we reassure them, and that we only remove any clothing as we need to determine and treat any of the injuries. Cannot reiterate that enough. Do not say anything that makes the child feel like this is their fault at all, and try to control your emotions. There could be a totally innocent explanation for whatever you are seeing, and you don't want to escalate anything into violence that could cause a safety issue for yourself, your partner, and then the child. When you're transporting a patient that is receiving care for sexual abuse, do not allow them to like clean or wipe certain areas of their body. Try to discourage them from using the bathroom. Do not give them anything by mouth. They're going to be doing a rape kit or a sexual assault kit at the hospital, so we want the body to be as like evidence filled as we can, I guess. I can't think of the like another way to describe it, but like there's words out for it. I need to watch more SVU or something. But we want them to be that unclean so we can find as much information as we can about the abuse. As seen in Chapter 4, it's not just children that are abused, elders are abused and neglected as well. And it will include a lot of the same physical and psychological abuse, but it also includes a lot of financial abuse. Adults that have developmental disabilities or physical impairments or other dependent situations may also be victims of abuse and neglect. So it's not just the pediatrics or the geriatrics. You need to recognize abuse very similarly to those of the geriatric and the pediatric patients. Here's some specific warning signs of adult abuse. Some of it could just be signs of hunger or malnourishment or improper toiletring. Maybe they are not being wiped or cared for or bathed, and they're just being neglected. EMTs are in charge of providing the emergency care for the injured patients, but we are not police officers or court investigators or even social workers. We need to gather information and then report the information to the proper authorities. We need to remain objective. There could be a reasonable explanation for this. We cannot assume guilt. We should talk to the caregiver about certain suspicions if it has to do with other family members or something. We should try to get the caregiver away from the patient to get, see if we can get a story from the patient and then see if we can get a story from the caregiver. So you may have to kind of separate from one side of the room to the other with your partner. You need to control your emotions and provide appropriate care. Do not indicate suspicions of abuse. Here in Alaska, there's actually phone numbers and websites that we use to report abuse and neglect. Even if it is not legally required, reporting is a professional obligation. So if you do move to a different state that does not require certain mandated reportings, but they have a system where you can report, it's still a very good, like, professional obligation to fulfill. Abuse and neglect, intimate partner, so we can go to a lot of domestic violence calls. Safety is priority. We need to make sure that we're safe, our partner is safe. These may or may not be mandatory reportings. We need to let them know that the highest risk is the patient leaving. So if we are trying to transport the victim of violence, they're more likely to be attacked again right before we leave. So that is a huge risk for safety. We need to pay attention, head on a swivel, ready to react, know where our egress is, know how to get a hold of law enforcement and how to get them to respond quickly, and where the assailant or the abuser is at all times. People stay in abusive relationships for multiple reasons. It could be a financial thing, it could be self-esteem. There is a plethora of different reasons why, and sometimes it's just, we just don't know. We don't know why they continue to be in that abusive relationship. We try not to pass judgment onto their decision of why they're doing that. Here are some different signs of partner violence that you can look over. With any abuse or violence, really it should say safety is always first, but you do need to attend to the medical issues first. There could be patients that refuse transport. It could be a skewed view of their personal safety. Maybe they believe that they're going to be attacked if they do leave with you. Try to be an advocate for this patient. Try to inform them of different means of help. There's many services that are free and very confidential. You can point out that there are some free hotlines. You can offer them any of the education that you can for the community that you live in. What your job is to gather as much information as you can and document it. Because if something does happen and they do refuse to transport, in the future, this information that you've documented and gathered could be used in a court to show like a pattern of abuse. So make sure that you report facts, you don't make up anything, and you try not to put any of your like own opinions in there. It needs to be objective. We do have what is considered kind of like a modern day slavery. Human trafficking does happen. It's even all the way here in Alaska. It is a federal crime. There is issues all over the world about human trafficking. It exposes victims to many abuses, malnutrition, sexually transmitted infections, many mental health issues. This will cause all sorts of other things that we've learned about in this chapter, with homelessness and poverty, and maybe some developmental problems. Maybe the person's being sexually exploited. They have a drinking problem. They end up having a child. This child has fetal alcohol syndrome, so you can kind of see how they start to kind of roll into each other. Here are some clinical presentations of human trafficking. Human trafficking is really, really hard to really see because some people come from other countries and they don't really know what the rules are. So it's more than just physical presentations. The main thing about human trafficking is a person is under the control of somebody else. They are not in control of themselves. So this could be all of their identification, passport, anything like that is being controlled. They have no control over their own finances. They are unaware of any like insurance paperwork, phone numbers, anything like that. They're just not able to know facts about themselves because the other person is in charge of all of that. Again, safety is always a consideration. Do not disclose your suspicions to any others at the scene. Many times trafficking is very sophisticated and there is a huge like web of people that are connected with it. These next few slides are just going to kind of cover the chapter review, basically all of the other 100 slides that we just covered. Special challenges are those that are homeless, impoverished, obese, sensory impairments, terminally ill, developmental disorders, or have machines that they rely on or are technologically dependent. You have to be able to distinguish the difference between a chronic condition and something that is more acute. Do not get tunnel vision into looking at only what their chronic issue is. Don't focus on the cerebral palsy. Do not focus on their obesity. Look at other things. So this one here has the example that a patient may have an anaphylactic reaction to a new medication, just like the more routine patients that we see. People that have autism or on the autism spectrum, we need to be aware that they may behave and react differently than other patients. We need to keep things basic. We need to remain calm, try to get them to remain calm, and safety. Safety is key. Safety for yourself, for the family members, and for the patient. Look to the family and the caregivers for a plethora of information. As technology improves, more equipment is out there, and it's actually increasing the lifespan, but it's also allowing more special challenged people, disabilities, special needs, chronic illnesses to actually live like longer normal life. So we are going to see this more and more as time goes on. Thank you for watching this presentation, and hopefully you guys learned a little bit about caring for those with special needs.